What I'm going to talk today is an opportunity to say something. I mean, living labs are proliferating rapidly, so there are a lot of hopes of their potential in various sectors. But because they're complex co-productive arrangements, it's actually quite hard to really say what difference do they make. And by a bit of luck, we got ourselves a possibility to do a comparative study on them. And that's what I'm going to talking about today. So as Robin said, I'm leading a group called Users and Innovation Research in Aalto University. We're 10 people, and what we do is that we're a multidisciplinary group of people. We do work in user-centered design, participatory design, open innovation, user communities, and the kind of most of these studies take the form of longitudinal studies on how design and use factually interrelate. And we, rather than developing normative methods, or we do some of that as well, we rather try to see how they play out in real-life settings to inform us better on what happens. And we've looked at across the board of different technologies. I spent much of the last decade looking at health technology. Since then, we've had quite a lot of work in social media. With Edinburgh folks here, we've looked at a little bit of ERP and CRM works. We've recently looked at citizen-built information infrastructures, open design, living labs, and distributed manufacturing, plus some other topics, but these are the sort of main areas. For this talk, it's one of the articles that go into Louna Hakkarainen's PhD thesis, which is soon to be completed. And it's a her work is a longitudinal study on how an innovation project in healthcare living lab plays out, and how the collaboration there happens. So on to the living labs. So living labs are seen as a real-life test and experimentation environments where users and producers co-create innovations. They have been characterized as public-private people partnerships for user-driven open innovation. This is the definition by European Network of Living Labs. The main activities would be co-creation, exploration, experimentation, evaluation. So focusing both on improving the technology, as well as oftentimes the rationale is experimenting with what new uses and what new uses the technology can be put, and what new development directions might emerge for new technology. The definitions that we have on living labs echo these ideas. Felsstad in 2008 notes living labs are environments for innovation and development where users are exposed to new ICT solutions in semi-realistic contexts as part of medium or long-term studies targeting evaluation of new ICT solutions and discovery of innovation opportunities. So this is basically, as you can see, wherever we pick the definitions, this is what living labs are supposed to do. And they're mushrooming quite rapidly. This is the European Living Labs page 2 years ago, when this paper came out. I'm assured there are plenty more by now. And so, even though Living Labs seems to be a sort of endorsed option by, for instance, the European community, and their mushrooming seems to hint that there can't be too much of a good thing, we are in a position where it's actually quite hard to tell what they are worth. If we have simple co-design techniques, say collaborative walkthrough or cart sorting or social science techniques like focus groups, it's actually quite easy to build experimental setups to assess their yield in comparison to either the components that are used in them, different variations, or alternatives as to what kind of outputs come through. However, as living labs are open-ended, sustained, and complex co-production arrangements, what they should be doing is the changing the very process direction and shape of the innovation process. And they're not amenable to this kind of experimental comparison, nor necessarily is it easy to find projects that could be projects in living labs and projects outside living labs that could be compared. In fact, before our study, we are aware of absolutely none of such comparisons. Okay, and this is because these kinds of complex co-production arrangements are affected by a large number of significant events and decisions made by participants and external stakeholders. They are very complexly shaped. They may take several years in terms of duration. And the resulting project trajectories henceforth can be argued to become highly particular and have high contingency as processes. And this is echoed with what we know of innovation processes, which we know are in fact long and winding journeys rather than orderly projects characterized by high uncertainty and contingency. And so what we are in a sense stuck with is that we have a complex co-production arrangement within complexly shaped innovation process, and we should be comparing these two. It's no miracle that these kinds of comparisons haven't occurred. We were of the opinion that this couldn't really be done before it turned out that we were having a bit of a piece of luck. I did for my own PhD in another galaxy in 2000s. I finished in 2004. I was studying this wrist monitoring technology for elderly. And in 2009, a master's student of mine came to look for a thesis topic, and I hinted to her that why don't you look at this living lab development on this elderly care living lab, and particularly this sensor floor, that sensoring floor technology that was being developed, because it's using some of the same, almost the same technology. It's almost in the same location, and as this is a living lab, it should take a very different shape. Okay? And so she embarked on first doing a master's thesis on it, then doing a licentiate, and now finalizing a PhD on it, reconstructing it historically and following it onwards in real time, what has happened. And in the course of her study, we became increasingly sort of surprised and aghast that, well, the grand difference that we were expecting wasn't really materializing. The two trajectories looked similar. They continued quite similar. There were some differences, but there were a lot of commonalities, much more commonalities than we had ever expected. And so at some point when her follow-up on this project or the reconstruction follow-up had lasted for next to a decade, we started looking at, okay, well, we have this hunch that there are these similarities. Okay, let's map them. Let's do more rigorous, more systematic study on these two projects and see, are they alike or are they unlike? What are the differences actually? And to do this kind of comparison started as a sort of bit of a playful project and grew increasingly serious, because we thought this can't be done. What we have as a background is okay, both are used for sheltered housing for elderly. They are both relying on movement censoring through similar basic technology. Both are have technology-driven startup history. Both originate as technology companies in the same city in Helsinki. They are targeted at same users and use context, and their first pilot is even in the very same elderly care institution. Okay, quite extraordinary. And both have struggled similarly. Both are up and running. So both have sort of been on the verge of failing and have managed to succeed to date. So there are a lot of commonalities that we can sort of bracket out in what they are. So the floor monitoring consists of a sensor foil which is installed under the flooring, and whereas in wrist device, obviously it is at the back of the device monitoring the health of the person from the wrist. The user interface for both of these monitoring and alarm devices, both are used for monitoring as well as alarms, are situated in nurse's office and routed to cell phones in which nurses carry with them during their work shifts. And what they inform about is slightly different. It has changed along the years slightly. And I skip the project details to get to the, or maybe I show, you know, what happens in the course of these innovation projects, and then go into the mapping. Okay, so if we look at this floor monitoring system, I'd rather not describe the Vivago because I've given so many talks on Vivago that half the audience here knows already way too much of that technology. But the floor monitoring technology, what happens in this innovation process is that from '96, this intelligent fall detection system is then entering a living lab collaboration with assumedly technically ready technology. In several years, it evolves onto a smart floor system, from fall detection to smart floor, where in contrast to detecting falls, it seeks to prevent them. It seeks to provide just-in-time care, seeks to provide more individualized care so that the elderly are not tied in their beds to allow them wandering at night, for instance. More leisurely care work, peaceful night shifts, less movement restrictions on the elderly, hence for more individualized care. And then on technical side, bugs being weeded out, whole new benefits and entirely new sales points, implementation requirements being clarified, and information on how it affects elderly and the nursing. Basically, the business case was entirely built in the course of the living lab. In the wrist monitoring, or in the Vivago case, we find very similar also. There begins from technologists, then enters in healthcare settings where quite a dramatic amount of redesigns ensues, and new uses, new value points, and then eventually a relatively successful artifact comes out and is generified to a broader clientele, which also happens in the floor monitoring case. Okay, so both these original case studies have been done based on social shaping of technology. The Finnish brand of the sort of biographies of technologies and practices that we started in '95 and have kept on since. I hopped on that research program in '99 and then sort of came to more or less appropriate it and come to lead it by 2004. And so we're very much interested, originally we were interested in looking at interaction and learning between developers and users already in '95. And that resonates with the social learning agenda here in Edinburgh very much. And so there are a lot of commonalities, as Robin points out, and we've tried to merge these frameworks into biographies of artifacts and practices framework. The type of data in both of these cases are quite typical for the kind of work that we do. We have interviews, we have quite a rich set of internal documents, memos, plans, project descriptions, correspondence, and so forth, which has been used for historical reconstruction of the process. And then we have field observation done by the researcher especially at the follow-up stage. So in this comparative mapping, what we do is that we sought to code and compare key events and interactions following Van de Ven Innovation Journey Works event mapping technique. So it means that key ideas, key outcomes, changes in people or technology, key interactions between designers and users, and issues about markets were mapped systematically. What we did was that we both read the longest versions of our original case descriptions. Then we both went on to identify, when reading both of these reports, we went on to identify what could be possible points of comparison, or sensible points of comparison. And 69 key points for comparison were found out from 82 initial candidates. And these were then consolidated into 52 points of comparisons for the role of living lab for designer-user relations and the innovation trajectory. And we then looked at these points, and we had database discussions, rummaging through the case studies once more, to evaluate the degree of difference or resemblance of each event. And you're going to see shortly what we did, how we did that. And so let's move on to the comparative mapping. If we look at, I apologize for this might not be very top visible to the back rows, but hopefully so. I shared the paper, so there it's more readable. Okay, so if you look at the initiation stage of these projects, we have 11 events that we compare in the starting points, in the sort of first 2 to 5 years of these projects, before any user collaboration really emerges. And we've coded this so that we have, on the left-hand side, we have high resemblance. Then here we have moderate resemblance. Then we have moderate difference and high difference. If we look at the starting points, both had engineering starting point. Both received encouragement for the innovation project from elderly care. There is a high difference in where the idea about viability came. In the floor monitoring case, the viability idea came from the elderly care side, whereas in the risk monitoring, it was developers, engineers' own assessment that this could be viable. The implicit idea of users and uses was similar. Alarm to readily awaiting healthcare personnel about the state of the elders. There is moderate difference in explicit market or user research, in that in a risk care, there was marketing studies that were done. In the floor monitoring, there was none officially done, but the elderly care actors actually knew quite well the market. So their assessment of viability actually included previous studies on markets, which they didn't conduct for this particular project. Early energy in both projects was targeted to technical development, not in exactly the same way, of course, but quite resembling. In the Vivago case, there were changes in key technical components in the early years, which didn't happen in the floor monitoring case. The floor monitoring technical development was a bit more smooth. Both had relatively tight funding, just slightly different sources of funding. And both were assuming that there's more or less ready product emerging out of R&D when the pilot users will be contacted. In the floor monitoring case, due to the living lab, there was some funding from the user side to the pilots in comparison to the rest care, and the target market for the risk care also included home use, but the primary market grew out to be the very same as with the floor monitoring. Okay, so what we see is we see some differences in these initial starting points, as you would expect, right? What really struck us was that, okay, then when we moved to the first pilots, one is in living lab, one is without it. You would think that the differences would now really go havoc. They don't. What we find is that the only difference there is that the other one, the continued technology development during pilot use, is done in, there's moderate difference in that in floor monitoring it's done in living lab, where the aim was originally develop the healthcare practices and not the technology, whereas in the risk monitoring, it was first in short pilot use and then to a small number of piloting participants. So there's a small network with the risk care and then single site co-development in the floor monitoring case. Whereas unneeded technical sophistication was reduced in both. Unexpected uses emerge in both. Unexpected variability in the conditions of elderly and how it matches onto the algorithm was encountered in both. The elderly were a much weaker condition in both cases than ever expected by the developers in both. Unexpected needs to integrate the technology onto the nursing work took place in both cases very similarly. The need to integrate the technology to other equipment used by nurses and rest homes was similarly unexpected for both projects. The need to invest into own network and software as a consequence was similarly unexpected, but similar in both projects. Unexpected contextual problems in fitting the technology into the physical locales were encountered in both very similarly. And all kinds of unexpected user behaviors were taking place. So what in the wrist care case the developers called bizarre user actions, which actually were quite rational when you look at it from the user perspective, but kinds of things that nobody was aware that were even taking place. When you introduce monitoring technology, things become visible, such as that the nurses were leaving piles of laundry onto the floor, lying there for some hours while they were doing care rounds. Of course they do that. Why would they always carry the piles of laundry out there? But when you have a sensor floor, it is just a very bad idea to leave a pile of laundry onto a sensor floor, which then records that as a human, so forth and so on. And installation and repair cost higher and hampered internationalization in both. So we see that on entering the living labs, the list of things that surface that were unexpected was very similar. What we find is that then the relation between developers and users, you would really expect that this would at least be very different in a living lab than in a technology project that's really technology centered. Okay, what we find is that there's similarity in that both users and developers expected the product being more or less ready at the implementation. In the living lab, there was a collaboration agreement and a plan which was lacking in the Vivago case. There was high tension in both of these cases on how much you localize and how generic an approach, a technology you pursue. There was a difference in pilot cost of work being shared in that living lab this took place, in the other project not. There was some resemblance in that there was new design aim, in that in both cases the development of better healthcare working practices was shifted onto technology development because the technology was just found not finished and not reliable enough at the point of implementation. In both cases, then, initial user interface was very difficult to use and caused a lot of interactions around that. In both cases, the nurses were highly frustrated by false alarms, as well as the interactions between developers and users. In both cases, the elderly care actors threatened to retreat from the collaboration categorically and return the devices and just stop it all. And in both cases, the technology company at this point realizes that they really need to engage into more listening mode and really start to solving the problems more effectively. And in both cases, the people who mediate between developers and users are under such high stress that these innovation intermediaries quit one after another. Okay. So if you look at the differences only result in that the other project happens to have a living lab agreement in place. Everything else also similar. Okay. If we then look at, in both cases, this initial crisis is resolved and a highly beneficial, mutually beneficial collaboration ensues. If we look at this maturing collaboration as well as the technology project, we find that in both cases 2.0 version then starts to fit the elderly care settings much better. There is no formal or outside neutral facilitator. In both cases, eventually there emerges a person who can successfully mediate between developers and users. But there's moderate difference in that this person in the wrist care case emerges from the company side. It's a technician who has done a lot of maintenance on other safety phone systems is hired into the company and manages to do this bridging role. Whereas in the healthcare or in the smart floor case, a nurse is being hired from the user side to act in the same position, reorganizes everything, and starts to act as effective liaison between the two parties. So it just emerges from different side, but does effectively the same functions. So we've coded that as moderate resemblance, not high resemblance. Okay. Also, in both cases, well-functioning form of development forms after quite serious investment in trying to find ways of working that really work. The differences come in that in the living lab, the management of the nursing home also exert pressure in getting things done. So the use of the technology is made mandatory, and feedback is made mandatory as well. Which, of course, without living lab you can't do this, or the elderly care institutions were unwilling to do this for the wrist monitoring technology. In both cases, all kinds of panopticon issues emerge. And suddenly you start seeing things that you weren't seeing before about how the elders, what the elders really do and what nurses really do in conjunction to the elders. And in both cases, this panopticon ability to see what happens at night becomes the major selling point. Because without that, as a precautionary measure, you need to check in, and in so doing, waking up the elders in doing so. Being able to just monitor, being able to really see what they're doing becomes a major selling point. In both cases, users also ideate new key value points, moving from fall detection and illness accident detection to prevention. It's the same shift happens in both cases, and it comes entirely from users, and how it's being done emerges entirely from the users, not from the developers. And then in both cases, high importance of reliability is agreed and emphasized by both parties when the collaboration matures and the parties start to understand where the other one is coming from. And similar end benefits ensue. In the final stages of the collaboration, then after the living lab, after the first pilots, when we look at it, we find again a very touching similarity in the sort of what Neil and Robin have called generification phase of the technology. So after the living lab, when this technology, and after the pilots, when this technology is spread to wider clientele, what we find is that in both cases you have rapid initial increase in the customer base. Only moderate difference is that the wrist care is also sold somewhat to homes, but in most the sales are in rest homes. And in floor monitoring case, the key issue is that most sales are in new rest homes. For wrist care, their profile, they could sell a bit better to also old rest homes, but also most sales were in new rest homes. Profitable operation was a challenge in both cases because of the local tailoring of the pricing models and so forth. Required funding needs to ownership changes. Both companies are having to do repeated rounds of funding that splinter their ownership structure. In both cases, further redesigns and further configurability of the technology to different settings are pursued. And again, in both cases, when going into new physical locales and new markets, again, new contextual difficulties ensue. In both cases, the companies, from their early pilot experience, now know what to do with them. So they are more proficient in meeting these challenges. And there is, in both cases, high toing and froing between do you seek partnerships or do you seek generic, more generic product and sort of oscillation as time goes by in what becomes emphasized. And new product versions are made in both cases. So to sort of wrap this up, what we see is that, yeah, the living lab might have made a difference, but it's not in the kind. You know, there's high resemblance on what happens in both projects. One, very technology-centered, having to form collaborations with elderly care actors only by basically forced to do so. The other one, willingly seeking living lab collaboration from the onset, but the challenges are very much similar. In both cases, interaction and learning between developers and users was paramount for changes and for a well-received product ever to emerge. And in either project, the collaboration required high levels of frustration and conflicts of interest, purposeful efforts to build the collaboration arrangements, and intermediary actors to champion it. And so what we can say is that there is a degree difference in how these challenges were met, in that the Living Lab seemed to have speeded up the entry and course of the redesign process. It also allowed the technology company to spread some of the development cost to the user side with legitimate reason or legitimate arrangement. And it mitigated some strain on the early customer relations for the company and also for customers engaging with the company. However, there was considerable strain also in the floor monitoring case. So what we conclude out of this is that, well, we think that we were able, for the first time, to compare two innovation projects where one used Living Lab and the other one didn't use Living Lab. And henceforth, we can say some things about health innovation projects conducted in Living Labs in healthcare. And what we infer is that sort of public-private partnership requires building specific relationships by which the relevant information can be made visible, transferred to, and acted on by the other party. A phrasing that we've used before, we've seen this kind of need for this interaction in all of the health technology projects that we've looked at. We've looked at 6 different healthcare projects, and we've seen a similar kind of patterning taking place in all of them. And we've used the wording that there's quite extensive learning for collaboration before there can be learning in collaboration. And it's only this learning in collaboration which is really beneficial. The learning for is really struggling and quite painstaking for the parties. And the Living Lab arrangement then, what it really appears to do is to offer a legitimation for trying such engagement and rationale for the resources and patience that the collaboration requires. And so maybe we should treat Living Labs as legitimated context and a sort of minimal checklist that has to be taken, that has to be sort of put in place for health technology projects to ever succeed. And so as they have to engage in, there's a high probability that they will have to engage in this in-depth collaboration, then Living Lab and what typically is thought of Living Lab entailing should be used as a kind of a checklist. Well, at least these things we need to be prepared for to face when we are going on with our technology project. And with that, thank you, and let's see if we have some questions. Very happy to clarify any issues. Thanks.